Two people came into the emergency department one day. The first one is 33-year-old Muriel, who came in with abdominal pain, a severe headache, and hyperventilation. One of Muriel's friends said that she caught her drinking antifreeze. The other one is 35-year-old Eustace, who came in with confusion and hypoventilation. Eustace also has duodenal ulcers, for which he has been taking antacids. Among other tests, an ABG was done for both individuals. The results showed that Muriel had a low pH along with low levels of bicarbonate and low levels of PCO2, while Eustace had a high pH along with high levels of bicarbonate and high levels of PCO2. Based on lab results, both individuals seem to have acid-base disturbances. Now, let's go back to the basics for a bit. So, in plasma, you can find carbon dioxide, or CO2, and water, or H2O. They're constantly mixing together in order to make bicarbonate ions, or HCO3-, and hydrogen ions, or H+. Similarly, bicarbonate ions and hydrogen ions can form CO2 and H2O. Now, bicarbonate ions are mostly regulated by the kidney and metabolism, while CO2 is regulated by the lungs. The blood pH, which corresponds to the hydrogen ion concentration, needs to stay in a very narrow range, between 7.37 and 7.42. Basically, the more hydrogen ions, the more acidic the blood is, and the lower the pH. Less hydrogen ions means the blood is more alkaline, and the higher pH. So let's say that bicarbonate ion levels decrease for some reason. In this case, the equation shifts to the right and more bicarbonate and hydrogen ions will be produced, and as a result, the blood becomes more acidic, so pH levels decrease. On the other hand, if bicarbonate levels rise, less hydrogen will be produced and the pH rises. Now, if CO2 increases, then the equation shifts to the right and the pH drops. If CO2 decreases, then the equation shifts to the left and the pH rises. Stay with us here. In practice, the Henderson-Hasselbalch equation is used to calculate the pH based on the bicarbonate and PCO2 values, where PCO2 represents the partial pressure of carbon dioxide. Now, in order not to overcomplicate things here, just remember, if bicarbonate goes up, or if PCO2 goes down, then pH increases. And if bicarbonate goes down, or if PCO2 goes up, then pH decreases. Now let's start talking about acid-base disturbances, which are divided into 4 types: metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. In order to determine which is which, the 4 high-yield parameters are pH, PCO2, bicarbonate levels, and compensatory response. Okay, so metabolic acidosis can happen either from the buildup of acid in our blood, which could be due to increased production, or ingestion. It can also happen because the body can't get rid of it, or from excessive bicarbonate loss from the kidneys or gastrointestinal tract. The main problem with all of this is that they lead to a decrease in the concentration of bicarbonate in the blood, so bicarbonate ion levels will be low, usually less than 20 milliequivalents per liter. Remember this, as it's very high yield. As a result, the pH is lower than 7.35, and as a compensatory response, there's immediate hyperventilation in order to eliminate more CO2. By eliminating more CO2, PCO2 lowers and less hydrogen ions are produced. Now, with metabolic acidosis, in order to determine the cause, we may need to check the anion gap, which equals sodium minus chloride plus bicarbonate. Normally, it ranges between 3 and 11 milliequivalents per liter. The reason that it's not zero is that there are some unmeasured anions, like organic acids, and negatively charged plasma proteins, like albumin. Now, based on the anion gap, there are causes of high anion gap metabolic acidosis, which happens when the anion gap is above 12 milliequivalents per liter, and normal anion gap metabolic acidosis, which happens when the anion gap is between 8 and 12 milliequivalents per liter. Let's begin with high anion gap metabolic acidosis. In this case, bicarbonate ions decrease when they bind to excess hydrogen ions, which results in the formation of carbonic acid, which subsequently breaks down into CO2 and H2O. These hydrogen ions can come from an increased organic acid production in our body. One such example is lactic acidosis, which is where decreased oxygen delivery to the tissues leads to increased anaerobic metabolism and the buildup of lactic acid. Another high-yield example is diabetic ketoacidosis, which could occur in uncontrolled diabetes mellitus, where the lack of insulin forces cells to use fats as primary energy fuel instead of glucose. Fats are then converted into keto acids, such as acetoacetic acid and beta-hydroxybutyric acid. Another way acids can build up in our blood is due to an inability of the kidneys to excrete them. This can happen in cases of chronic renal failure in the uremic phase. In other cases, hydrogen ions don't come from inside our bodies at all, but instead they're accidentally ingested. These include oxalic acid, which can build up after an accidental ingestion of ethylene glycol, which is used in antifreeze, and formic acid, which is a metabolite of methanol, a highly toxic alcohol. Salicylates overdose can also lead to high gap metabolic acidosis in the later phases, due to the buildup of hydrogen ions in the blood. Finally, there are certain substances that can lead to metabolic acidosis by promoting anaerobic metabolism and, in turn, lactic acid production. These are propylene glycol, iron overdose, and isoniazid overdose, which you have to know for your exams. To sum up, you can remember the causes for metabolic acidosis using the mnemonic MUD piles, where M is for methanol, U is for uremia, D is for diabetic ketoacidosis, P is for propylene glycol, I is for iron tablets and isoniazid, L is for lactic acidosis, E is for ethylene glycol, and finally, S is for salicylates. In contrast, in normal gap metabolic acidosis, the decrease in bicarbonate ions is offset by the buildup of chloride ions, which are part of the anion gap equation, so the anion gap remains normal. The most common cause is severe diarrhea, where bicarbonate-rich intestinal and pancreatic secretions rush through the gastrointestinal tract before they can be reabsorbed. Another cause is type 2 renal tubular acidosis, where acidosis develops because the proximal convoluted tubule is unable to resorb bicarbonate, so it's lost in the urine. Other types of renal tubular acidosis also result in normal anion gap metabolic acidosis, but the underlying mechanism is an inability to excrete protons in the urine. The excessive loss of bicarbonate ions results in a lower pH. Another cause is Addison disease, where the adrenal glands don't produce enough steroid hormones, including aldosterone. Normally, aldosterone tells the kidneys to reabsorb more sodium in the distal tubule, and this is linked to hydrogen ion secretion, meaning as sodium is reabsorbed, hydrogen is secreted. Since there's not enough aldosterone, less sodium is reabsorbed, and more hydrogen will remain in the blood, leading to metabolic acidosis. Similarly, Spironolactone can lead to metabolic acidosis by blocking aldosterone receptors. Another cause is the use of acetazolamide, which lowers bicarbonate reabsorption in the proximal tubule, leading to bicarbonate wasting and metabolic acidosis. Now, in some cases, saline infusion can lead to metabolic acidosis, and that's because the standard 0.9 saline solution has a pH around 5.5. Finally, total parenteral nutrition can lead to metabolic acidosis because it leads to the accumulation of hydrogen ions. And finally, in cases of chronic metabolic acidosis, the kidneys will try to compensate for the low bicarbonate levels with renal ammoniogenesis. This is when the renal tubular epithelial cells convert glutamine to glutamate to create ammonia and bicarbonate as byproducts. The bicarbonate can then be reabsorbed into the blood, while the ammonia is lost through urine. To sum up, causes of normal gap acidosis can be remembered using the mnemonic HARD-AS, where H stands for hyperalimentation, A for Addison disease, R for renal tubular acidosis, D for diarrhea, A for acetazolamide, S for spironolactone, and the other S is for saline infusion. Now, hang in there for one last fun fact about metabolic acidosis. You can actually calculate if the respiratory compensation is adequate in metabolic acidosis by using Winter's formula. So, for example, let's say that our bicarbonate is 15. Then, the calculated arterial PCO2 is 1.5 times 15 plus 8 plus or minus 2. So 1.5 times 15 is 22.5, and 22.5 plus 8 is 30.5. So it's 30.5 plus or minus 2, so the range is 28.5 to 32.5. So if the measured PCO2 is between 28.5 and 32.5, then there's an appropriate respiratory compensation for the metabolic acidosis. If the measured PCO2 comes back greater than calculated, then there's a metabolic acidosis and an associated respiratory acidosis. If the measured PCO2 is lower than calculated, then there's a metabolic acidosis and an associated respiratory alkalosis. And remember this for your tests. Let's now move on to respiratory acidosis, where the normal mechanism of ventilation is disturbed and is inadequate to balance the pH. The high-yield concept here is that this is a result of hypoventilation, which leads to the accumulation of CO2. So the main problem here is the rise in PCO2, usually above 44 millimeters of mercury. As a result, more hydrogen ions are produced and pH levels decrease. In order to compensate for the acidosis, bicarbonate levels increase and the kidneys will eventually increase the absorption of bicarbonate ions. Now, unlike the respiratory response for metabolic acidosis, which happens immediately, the kidneys take time to increase bicarbonate levels. This can take around 24 hours of persistent respiratory acidosis before the delayed compensation takes effect. This is why in acute respiratory acidosis, the pH is very low, while the bicarbonate ions are only slightly elevated or normal. In chronic respiratory acidosis, the kidneys can often compensate enough to bring the pH closer to the normal range, and there will be very elevated bicarbonate ions, typically over 30. Now, to remember the causes of respiratory acidosis, we must think about causes of hypoventilation. One reason is airway obstruction, which might happen if a child aspirates an object like a peanut and it lodges in the right mainstem bronchus, preventing that lung from ventilating. Sometimes the diaphragm or chest wall muscles don't work properly, which can happen after severe trauma or due to obesity when the chest wall is too heavy for the muscles to lift. There might also be impaired gas exchange between the alveoli and the capillaries. That might happen if alveoli are damaged from chronic obstructive pulmonary disease, or in acute conditions like pulmonary edema. Sometimes the problem isn't in the lungs themselves, but in the respiratory centers of the brainstem. After a stroke or a medication overdose, like with opioids or sedatives, the respiratory centers can slow their rate of firing, so breathing becomes extremely slow or stops entirely. Now, to easily remember the causes of respiratory acidosis, let's imagine a cow that's breathing slowly, as a cow. A for airway obstruction, S for sedative use, A for acute lung disease, C for chronic lung disease, O for opioids, and W for weakening of the respiratory muscles. Now, let's move on to metabolic alkalosis, and the high-yield concept here is that this can typically arise in two ways: loss of hydrogen ions and gaining of bicarbonate ions, or most often, a combination of these two. Whatever the cause, there's an increase in bicarbonate levels, usually above 28 milliequivalents per liter, which will cause the pH to rise. As a compensatory response, there will be immediate hypoventilation, which will retain more CO2 and in turn increase levels of PCO2. Now, loss of hydrogen ions can occur either from the gastrointestinal tract or from the kidneys. The first case most commonly happens during vomiting, because the gastric secretions are very acidic, meaning that they contain a lot of protons. So, during vomiting, not only is the stomach acid lost, but in addition, the pancreas doesn't secrete bicarbonate into the intestines, and it builds up in the blood instead. Another way that hydrogen ions can be lost is through the urine, in the context of having too much aldosterone hormone, and this is called hyperaldosteronism. Remember, aldosterone causes the kidneys to reabsorb sodium, excrete hydrogen ions, and reabsorb bicarbonate. The result is that the urine becomes more acidic and the blood becomes more alkaline. Moving on, increased bicarbonate ions are usually caused by an increased reabsorption from the kidneys. One way this can happen is volume contraction or excessive loss of extracellular fluids. When a lot of fluid is lost, but not as much bicarbonate ions, we get alkalosis, and this can occur with the use of loop diuretics. The resulting alkalosis is called a contraction alkalosis. Now, in other cases, excess bicarbonate ions don't come from within our bodies at all, but are ingested in large amounts, usually in the form of antacids, like sodium bicarbonate. Now, to easily remember the causes of metabolic alkalosis, think LAVA up, where L stands for loop diuretics, A stands for antacid use, V for vomiting, and A up is for aldosterone increase. Finally, with respiratory alkalosis, the normal mechanism of ventilation is also disturbed, but this time there's hyperventilation, and more CO2 is eliminated through the lungs, and as a result, there's decreased levels of PCO2, usually lower than 36 millimeters of mercury. In turn, pH levels increase, and in order to compensate, bicarbonate levels decrease when the kidneys decrease bicarbonate ion reabsorption. Now, for ventilation to increase, the respiratory centers have to start firing more than usual. This increased firing can be a normal compensatory response, or an abnormal response to a situation that doesn't really call for hyperventilation. Hyperventilation is a normal response to things like hypoxia, which can happen with pulmonary embolism. Another way this can happen is when a person climbs a high mountain, like Mount Everest. This is because as we climb, levels of oxygen decrease, causing hypoxemia, which triggers hyperventilation. But increased ventilation can be an abnormal response that sometimes happens in situations like anxiety and panic attacks, or in overdoses with salicylates in the early phases. Sometimes a tumor in the brain can stimulate respiratory centers, leading to hyperventilation. Now, to remember the causes for respiratory alkalosis, think past pH. Okay, so P is for panic attacks, A is for anxiety attacks, S is for salicylates, T is for tumor, P is for pulmonary embolism, and H is for hypoxemia. Think about high altitudes here. Alright, as a quick recap, with metabolic acidosis, there's a decrease in bicarbonate ions, which results in a low pH and low pCO2 values, and there's immediate hyperventilation as a compensatory response. With metabolic alkalosis, there's an increase in bicarbonate ions, which results in a high pH and high pCO2 values, and there's an immediate hypoventilation as a compensatory response. With respiratory acidosis, there's an increase in pCO2, which results in a low pH and high bicarbonate ion levels, and to compensate, there's an increased renal bicarbonate ion reabsorption. But this usually takes longer to take effect, so it's delayed. And finally, with respiratory alkalosis, there's a decrease in pCO2, which results in a high pH and a decrease in bicarbonate ion levels, and there's delayed decreased renal bicarbonate ion reabsorption. Now, back to our cases. As we can recall, Muriel came in with hyperventilation, and her ABG showed low pH along with low bicarbonate and low pCO2. Now, her history showed that Muriel drank antifreeze, which we know to contain ethylene glycol, which is an organic acid that causes symptoms like abdominal pain and severe headaches. Now, given the history and the ABG results, Muriel most likely has metabolic acidosis with a high anion gap. This can be confirmed by calculating the anion gap, where we will need an electrolyte panel in order to see what the values of sodium and chloride are. Moving on to Eustace, he came in with hypoventilation, and the ABG showed high pH, along with high bicarbonate and high pCO2. Now, his history is positive for duodenal ulcers being treated with antacids, which we know are a cause of metabolic alkalosis. So given his history and the ABG results, we can say that Eustace has metabolic alkalosis, and he's compensating through hypoventilation.
Two people came to the nephrology ward one day. The first is 29-year-old Dan, who presents with hypertension, gross hematuria, and flank pain. Dan's family history showed that his grandmother died of a Barry aneurysm. Next is 35-year-old Heather. She does not present with any symptoms, but she has been referred to the nephrology clinic because her primary care doctor discovered that her kidneys have a weird shape on an abdominal x-ray. Both individuals underwent abdominal ultrasound. Dan had many cysts of different sizes on both kidneys, while Heather's kidneys are located lower than normal and appear fused together. Both Dan and Heather have congenital renal disorders. The renal system starts developing during week 4 of intrauterine life. It comes from the mesoderm, which is one of the 3 primitive germinal layers. More specifically, it develops from a portion of the mesoderm called the intermediate mesoderm. The intermediate mesoderm on either side of the embryo condenses to form a cylindrical structure called the urogenital ridge, and a portion of the urogenital ridge called the nephrogenic cord gives rise to the urinary structures. During renal development, the nephrogenic cord gives rise to 3 sets of structures. The non-functional pronephros in the embryo's head region, which regresses by the end of week 4. Then the mesonephros forms, appears in the thoracic and upper lumbar region, and acts as temporary kidneys until they regress in week 12. Finally, the metanephros develops in the pelvic region, and it forms the permanent kidneys. Alright, the metanephros sprout small buds called the ureteric buds. At the same time, the intermediate mesoderm gives rise to another tissue called the metanephric blastema. The blastema releases growth factors that stimulates the ureteric bud to become the ureter. The renal pelvis, the renal calyces, and the collecting ducts. Meanwhile, the ureteric bud releases growth factors that cause the metanephric blastema to develop into nephrons. At around week 20, the metanephric kidneys take over urine production, and this becomes the major source of amniotic fluid. As they continue to grow, they move up from the pelvis to reach their adult position. Alright, so if there's a problem during development of the kidneys, we can get oligohydramnios, or deficiency of amniotic fluid. As a result, a number of things can happen, leading to the so-called Potter sequence. With less amniotic fluid, there's pulmonary hypoplasia. Not only that though, with less amniotic fluid, there's less space in the amniotic sac, and so the fetus is literally compressed into a smaller space, which causes developmental abnormalities like a flattened face, wrinkly skin, low-set ears, as well as limb abnormalities like clubbed feet. Some renal conditions make it impossible for urine to be excreted, in which case there'll also be renal failure in utero. Okay, now one high-yield fact is remembering the specifics for Potter sequence. And we have a mnemonic for that. P is for pulmonary hypoplasia, O is for oligohydramnios, the first T is for twisted face, the second T is for twisted skin, E is for extremity defects, and R is for renal failure. Alright, so now let's talk about each of the congenital renal disorders. To make things easier, we can split them into cystic and non-cystic disorders. The first cystic congenital renal disorder is polycystic kidney disease. Based on the inheritance pattern, this can further be split into autosomal recessive polycystic kidney disease, or ARPKD, and autosomal dominant polycystic kidney disease, or ADPKD. With ARPKD, someone inherits a mutation on both copies of the PKHD1 gene, which codes for the fibrocystin protein. Fibrocystin is found in the collecting ducts, as well as in the epithelial cells of the hepatic bile duct. The lack of fibrocystin leads to cystic dilation of the collecting ducts in both kidneys. Individuals with ARPKD can develop Potter sequence in utero, and the most common cause of death in these individuals is pulmonary hypoplasia. If they don't develop Potter sequence, then after birth they develop progressive renal failure and systemic hypertension. The liver is also affected and they can have congenital hepatic fibrosis, which leads to portal hypertension. Autosomal dominant polycystic kidney disease, or ADPKD, is more common and the symptoms usually develop in adulthood. ADPKD is an inherited genetic disorder mostly caused by mutations in the PKD1 gene, but mutations can also happen in the PKD2 gene. Now, PKD1 and PKD2 code for polycystin 1 and polycystin 2 proteins, respectively. In the nephron, polycystin 1 and 2 inhibit cell growth and proliferation through signaling pathways that aren't well understood. Now, a person who develops ADPKD would have inherited a single mutation in PKD1 or PKD2. This leaves one functional copy of the gene in every cell, which allows for the production of polycystin 1 or polycystin 2. However, there's something called the second hit theory. This means that a random mutation can happen in the remaining good copy of the gene later in life. This disrupts the regulation of renal cell growth and proliferation, leading to cyst formation. Over time, these cysts will fill with fluid and enlarge, causing damage to the surrounding tissue, hypertension, and flank pain. Eventually, this will cause kidney damage. Now, if there's hypertension and signs of kidney damage like proteinuria, the best treatment is with ACE inhibitors or ARBs. Now, it's important to remember ADPKD affects other organ systems too. Individuals can have cysts pop up in their liver, which will lead to liver failure. They're also more likely to develop baryaneurysms in the cerebral arteries, usually in the circle of Willis. These can rupture and cause subarachnoid hemorrhage. Some individuals might also present with mitral valve prolapse or diverticulosis. For your tests, some clinical clues that should make you think of ADPKD include flank pain, hematuria, hypertension, and a family history of sudden death due to aneurysms. If hypertension is present and/or proteinuria develops, the treatment of choice is ACE inhibitors or ARBs. Another cystic disorder is medullary sponge kidney. Like ARPKD, this is present at birth. Although the precise mechanism is unclear, there's abnormal induction of the metanephric blastema by the ureteric buds, and cystic tubules develop in the nephrons, which gives the kidney the appearance of a sponge. The hallmark feature is cysts that form around the collecting ducts in the medulla of the kidney, causing them to dilate. Even though medullary sponge kidney is present at birth, it's usually asymptomatic and discovered in adulthood. With medullary sponge kidney, there's urinary stasis due to the cyst compressing the surrounding structures, and sometimes there's hypercalciuria, which makes the individuals prone to complications like nephrolithiasis. Next, we have multicystic dysplastic kidney, which is a type of non-inherited congenital kidney disease, where ureteric buds fail to induce differentiation of metanephric blastema. As ureteric bud fails to produce ureters, renal calyces, collecting ducts, and collecting tubules, filtered urine is unable to exit the kidneys. This results in a buildup of urine and formation of multiple fluid-filled cysts that are composed of abnormal connective tissue. In most cases, multicystic dysplastic kidney is unilateral, and it can go undiagnosed since the other kidney compensates the renal function. But in some neonates, health professionals can detect palpable flank mass, and then an ultrasound must be performed. In rare cases, multicystic dysplastic kidney can be bilateral, and then it leads to Potter sequence. Finally, we have medullary cystic kidney disease. Now, although it's in our cystic kidney disease section, development of cysts is actually not that common. So the newer term is autosomal dominant tubulointerstitial kidney disease. Here, mutations in genes that code for mucin or uromodulin cause dysfunctional protein synthesis, which leads to tubulointerstitial fibrosis and the occasional cysts in the medulla and corticomedullary junction. Over time, this leads to renal insufficiency with inability to concentrate urine, and eventually renal failure. Now, an important clue is that children with this disorder are more likely to develop gout at a young age. A kidney ultrasound shows small-sized kidneys, while medullary cysts are usually not visualized. Okay, so now let's move on to non-cystic congenital disorders. First, there's renal agenesis, which is when one or both kidneys do not form. With renal agenesis, the ureteric bud fails to induce development of the metanephric blastema, and so either one or both kidneys don't develop. Although not completely known, it's thought that this is a result of a combination of genetic as well as in utero environmental factors, like toxins and infections. When renal agenesis is bilateral, it leads to renal failure in utero and Potter sequence, and this is not compatible with life. When one kidney is formed and functioning, this is called congenital solitary functioning kidney. The person is usually asymptomatic, but the solitary kidney needs to do all the work, so there will be hypertrophy and over time there's a risk of renal failure due to hyperfiltration. Next, we have duplex collecting system, where the ureteric bud either splits or arises twice from the mesonephric duct. Based on the level of fusion, duplex collecting system can present as bifid renal pelvis, partial ureteral duplication, also known as Y-shaped ureter, incomplete ureteral duplication, or V-shaped ureter, where the ureters join together near or in the bladder wall, and complete ureteral duplication, where the duplicated ureter has the separate ureteric opening. Now remember that this congenital disorder is highly associated with other abnormalities of the urinary tract, like ureterocele. With this condition, the part of the ureter that enters the bladder swells like a balloon, thereby obstructing the flow of urine. Eventually, ureteral obstruction can lead to vesicoureteral reflux and frequent urinary tract infections. Moving on to posterior urethral valves, or PUV, which is a congenital disorder in genetic males. Normally, the mesonephric duct fuses with the cloaca, leaving behind the remnants of this process called plicae caliculi. But in posterior urethral valves, there's an abnormal fusion of the mesonephric duct and cloaca, which leads to the formation of membranous folds, or flaps of tissue. These membranous folds obstruct the posterior urethra and cause bladder outlet obstruction. Now, it's important to remember that PUV is the most common cause of bladder outlet obstruction in males, and it can be diagnosed by prenatal ultrasound, which can show a dilated bladder, thickened bladder wall, and bilateral hydronephrosis. Finally, we have horseshoe kidney, where the two kidneys fuse together during fetal development. Between the 4th to 6th week, the kidneys are pretty close together, and it's thought that some flexion or growth of the developing spine and pelvic organs essentially squish them together. This allows the inferior poles of the kidneys to touch and fuse, forming what's called a fibrous isthmus. Horseshoe kidney is also associated with chromosomal aneuploidy syndromes, like Turner syndrome, trisomies 13, 18, or 21. They can also be caused by teratogens, like thalidomide or alcohol. Whatever the cause, during the 7th and 8th weeks, the fused kidneys try to migrate up into the abdomen, where they get trapped under the inferior mesenteric artery, which keeps them lower in the abdomen than normal. Now, the kidneys function normally at first, but due to the abnormal anatomy of the kidneys, there can be urinary stasis, which increases the risk for urinary tract infections and kidney stones. There could also be ureteropelvic junction obstruction that prevents urine from flowing from the renal pelvis into the ureters. Both kidney stones and UPJ obstruction can block normal urine flow, causing the kidneys to swell up, leading to hydronephrosis. Alright, as a quick recap. Renal congenital disorders can be split into cystic and non-cystic. Cystic disorders include ARPKD that can either present in utero or after birth, ADPKD that mostly presents in adulthood, and medullary sponge kidney. Non-cystic disorders include renal agenesis that can be bilateral, in which case a person develops Potter sequence in utero. Then there's unilateral renal agenesis, and finally horseshoe kidney. Coming back to our cases, Dan has ADPKD and the cysts in his kidneys are causing the hematuria and flank pain. Another clue is that Dan also has a family history of Barry aneurysms, which is common with ADPKD. Regarding Heather, she has an asymptomatic horseshoe kidney, which does not need regular reevaluation, but she's more likely to develop kidney stones and UTIs.
Two people come to the emergency department during your shift. One of them is 75-year-old Karen, who has palpitations and muscle weakness. Karen also has heart failure, and one of the medications she's currently on is digitalis. The other one is 25-year-old Carmen, who has tetany. On the clinical examination, Carmen has a positive Chvostek sign. In both these individuals, an ECG was done and levels of electrolytes were taken. Karen's ECG showed a wide QRS complex with peaked T waves and high levels of potassium, while Carmen's ECG showed prolonged QT and low levels of calcium. Okay, now let's start talking about electrolytes and what happens when their levels are either too high or too low. Let's begin with potassium, which is a cation that's mostly in the intracellular fluid, or ICF for short. It's essential for the normal functioning of excitable tissues, such as nerves and muscles, including the cardiac muscle, and also maintains the resting membrane potential. So, with hyperkalemia, there's too much potassium in the extracellular fluid, or ECF. And in order for there to be hyperkalemia, there are two possibilities. The first is an external balance shift, like when there's decreased potassium excretion by the kidneys, leading to an increased serum potassium. There's also an internal balance shift, where potassium moves out of cells and into the interstitium and blood. One potential cause is hyperosmolarity. Osmolarity reflects the number of solute particles per liter of solvent. And normally, the osmolarity of the ICF equals the osmolarity of the ECF, even though the exact composition of the solutes differs. So when there's hyperosmolarity, this means that there's something in the ECF that creates an osmotic force capable of dragging water from inside the cells, like glucose, for example. As water leaves the cells, the intracellular potassium concentration increases, and this creates a driving force for potassium to leave the cell, leading to a rise in extracellular potassium and hyperkalemia. Next, acid-base disturbances also play a role in this. pH reflects the concentration of hydrogen ions, and normal blood pH is about 7.4. To maintain pH balance, hydrogen moves in and out of the cells. In order for hydrogen to move across the cell membrane, it must be accompanied by an anion, meaning an ion with a negative charge, or it must be exchanged for another cation, like potassium. When there's an increase in the hydrogen ion concentration in the blood, this is called metabolic acidosis. As a coping mechanism, hydrogen must enter the cells in exchange for potassium, which leaves the cells, and this leads to hyperkalemia. Another important mechanism is the sodium-potassium ATPase, which normally transports sodium out of the cell and potassium in. Commonly tested medications like digitalis and beta blockers block the sodium-potassium ATPase, so more potassium is left outside the cell, leading to hyperkalemia. Another medication that causes internal potassium balance shift is succinylcholine. Succinylcholine combines with nicotinic receptors to inhibit neuromuscular transmission and produce skeletal muscle depolarization, which leads to relaxation. With depolarization, some of the potassium gets out of the cell, which in turn causes hyperkalemia. Finally, there's cell lysis or cell damage. When cells are destroyed, they release all their potassium into the ECF, which naturally leads to hyperkalemia. Some examples of cell lysis includes crush injuries, like when a piano falls on someone's legs, or tumor lysis syndrome, which occurs when cancer treatment causes lots of tumor cells to die all at once, or rhabdomyolysis, which is the rapid destruction of skeletal muscle cells. All right, on to external potassium balance shifts resulting in hyperkalemia, which has to do with potassium intake and excretion. That said, simply taking in too much potassium can lead to hyperkalemia, but this would typically arise from rapid, excessive infusion of potassium into the bloodstream, like in individuals receiving intravenous fluids. Most other cases have to do with the kidneys and their ability to regulate what stays in the blood and what gets excreted into the urine. Now, an important hormone that helps regulate potassium reabsorption or secretion in the kidneys is aldosterone. Aldosterone promotes potassium secretion by the principal cells of the distal tubule and collecting duct of the nephron. So in situations where somebody's unable to produce enough aldosterone, which is called hypoaldosteronism, there's less potassium secretion by the principal cells, and therefore more potassium is retained, leading to hyperkalemia. Along the same lines, medications that reduce the effect of aldosterone can also cause hyperkalemia, and these include renin inhibitors, ACE inhibitors, angiotensin II receptor antagonists, selective aldosterone blockers, and potassium-sparing diuretics. Acute and chronic kidney injury can also cause hyperkalemia because both can impair potassium excretion. Some associated clues include oliguria or anuria, which means decreased or no urine excretion, volume overload, and in advanced stages, uremia, which refers to the accumulation of uremic toxins, including urea itself. Moving on to causes of hypokalemia, which is when there's too little potassium in the ECF, there are similarly two possibilities. The first is an external balance shift, most often caused by an increase in potassium excretion in the kidneys, and the second is an internal balance shift where potassium moves into the cells from the interstitium and blood. One high-yield cause of internal potassium shift is hypoosmolality, meaning there are too little osmotic substances, like when there's hyponatremia, for example. Then the water goes back into the cells and can sometimes even drag potassium along with it, leading to hypokalemia. However, bear in mind that alternatively, in some cases of hyperosmolarity, like in a hyperglycemic hyperosmolar state, or HHS, which is a complication of diabetes mellitus, osmolarity can get so high that it leads to osmotic diuresis. Osmotic diuresis can also drag that potassium into the urine, and this may lead to total body potassium loss and hypokalemia. Now, with acid-base disturbances, when there's a primary decrease in the hydrogen concentration in the blood, this is called metabolic alkalosis. As a coping mechanism, hydrogen must leave the cells in exchange for potassium. More potassium gets inside the cells, and this leads to hypokalemia. Next, there are things that affect the sodium-potassium ATPase. Specifically, beta agonists promote the activity of the sodium ATPase, leading to hypokalemia. Next, there's insulin, which normally stimulates the sodium-potassium ATPase. When there's insulin deficiency, like with diabetes mellitus, there can also be hyperkalemia, and when there's too much insulin, there can be hypokalemia. Moving on to external potassium balance shifts resulting in hypokalemia, these have to do with potassium intake or excretion. Low potassium intake is rare since potassium is abundant in most foods, so it typically happens in cases of anorexia, prolonged fasting, or specific types of diets. excess potassium excretion from the kidneys is a lot more common. In situations where somebody produces too much aldosterone, like primary hyperaldosteronism, called Conn syndrome, there's more potassium secretion by the principal cells, meaning more gets excreted in the urine. Other pathological conditions that cause increased aldosterone levels include compensated heart failure and cirrhosis. For your exams, it's important to know that loop diuretics and thiazide diuretics also increase potassium excretion in the urine. Alternatively, potassium can be lost through increased gastrointestinal secretions, typically due to vomiting and diarrhea, like from infections, inflammatory bowel diseases, as well as laxative abuse. Finally, a very small amount of potassium is also lost in sweat, which could come up in your test as an individual who exercises a lot in a hot climate. Now, once a person has hypo or hyperkalemia, the first thing to do is an ECG. That's because the resting membrane potential of the cardiomyocytes depends on potassium balance. With hyperkalemia, the main changes are wide QRS complexes and peaked T waves, which put a person at risk for heart arrhythmias. This happens because initially, the rise in potassium in the ECF makes the cell membranes less electronegative, and this increases the membrane excitability, so cardiac muscles contract more easily, but it can't repolarize effectively to allow another contraction. For your tests, remember that another symptom of hyperkalemia is muscle weakness. With hypokalemia, the main changes are flattened T waves and the appearance of U waves, which are thought to represent the repolarization of Purkinje fibers of the heart. This happens because hypokalemia increases both the resting membrane potential and the duration of the refractory period, but has a greater effect on the refractory period, meaning it takes longer for the heart to recharge. It also decreases conductivity, which can further lead to heart arrhythmias. Other symptoms of hypokalemia include muscle weakness, muscle cramps, or spasms. Let's move on and talk about sodium, which is a cation that's mostly in the ECF and is essential for maintaining water balance, as well as nerve impulse conduction and muscle contraction. So with hypernatremia, there's too much sodium in the extracellular fluid. This can happen because a person has gained more sodium than water, or has lost more water than sodium. Either way, this increases the sodium concentration in the extracellular fluid, draws water out of the cells. Sodium gains happen most commonly when someone in the hospital is given too much sodium intravenously too quickly. The other possibility is salt poisoning, which is a rare scenario, but if it is seen, it's typically in infants and young children who have been abused. Water losses, on the other hand, are much more common and can result in hypernatremia if the lost water is not replaced. There are three possible sources: skin, gastrointestinal, and urinary losses. Increased skin losses can occur in individuals with extensive burns, fever, exercise, and exposure to high temperatures. Then we have the gastrointestinal losses, like vomiting or diarrhea. Finally, too much water can be lost through the kidneys because of osmotic diuresis. This occurs when the osmolarity of the fluid in the renal tubules is too high and it sucks more water into the tubules, which is then lost as urine. A high-yield example of this is diabetes mellitus, when there's too much glucose being filtered into the pre-urine. Other examples include acute kidney failure, when urea builds up, or during treatment with mannitol, which is an osmotic diuretic. When there's hypernatremia, water will move from the ICF to the ECF until both compartments become isotonic. This means that the cells will lose water and become dehydrated. When neurons are affected, it can lead to symptoms such as irritability, stupor, which is when a person becomes almost unconscious, and even coma. On the other hand, true hyponatremia, or low concentration of sodium in the extracellular fluid, can be caused by either losing more sodium than water or gaining more water than sodium. This shouldn't be confused with false hyponatremia or pseudo-hyponatremia. This is where the body water and sodium levels are normal, but there's an excessive amount of lipids, like in hypertriglyceridemia, or proteins, like in multiple myeloma. High levels of lipids and proteins affect the laboratory instruments that measure the sodium concentration, making the instruments say the sodium concentration is too low. Broadly speaking, true hyponatremia can be divided into three categories based on water volume status. The first is hypervolemic hyponatremia, where there's an increase in total body water with a less significant increase in total body sodium. Typically, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome, which all present with edema, especially in the ankles. The second category is hypovolemic hyponatremia, where there's a small decrease in total body water with a large decrease in total body sodium. This can occur in conditions like diarrhea or vomiting, or in response to certain medications like diuretics. Another, more nuanced condition is cerebral salt wasting, which is when an intracranial injury, like meningitis, disrupts the normal sympathetic nervous system stimulation of the kidneys, leading to disproportionate loss of sodium and, along with it, water. A third category is euvolemic hyponatremia, or normal volume hypovolemia, which is when there's normal body sodium with an increase in total body water. However, we call it euvolemic because there's no edema. Euvolemic hyponatremia can be split into cases with dilute urine and concentrated urine. Conditions that cause dilute urine include drinking too much water, called polydipsia, but the main condition that causes concentrated urine is the syndrome of inappropriate antidiuretic hormone secretion, or SIADH for short. Certain neurological disorders can increase the secretion of ADH, and this includes strokes, hemorrhages, or trauma, while certain medications like mood stabilizers and antiepileptics can also increase its secretion. It could also be excreted ectopically by tumors, and small cell lung carcinoma is the most commonly tested. When there's hyponatremia, water will move from the ECF to the ICF, so the cells will swell up. When neurons are affected, it causes symptoms like nausea, malaise, stupor, coma, and even seizures. Okay, moving on to calcium, which is a cation that's mostly located in the bones and is essential for muscle contraction, enzyme activity, and blood coagulation. It also helps with releasing neurotransmitters from neurons, as well as releasing hormones from the endocrine glands. About 1% of calcium is in the ECF. Now, hypercalcemia, or too much calcium in the ECF, is most commonly caused by excess parathyroid hormone secretion by the parathyroid glands, and is known as PTH-mediated hypercalcemia. This results in increased osteoclastic bone resorption. This is where osteoclasts break down the bone and release calcium into the blood. Hypercalcemia can also be parathyroid hormone-related protein, or PTH-RP mediated. PTH-RP is a hormone that mimics the effect of parathyroid hormone, so it stimulates osteoclasts. It can be secreted by various malignancies, but for your exams, remember squamous cell carcinomas of the lung. Other malignancies like multiple myeloma, breast, and lung cancer can also cause hypercalcemia, but without secreting PTH-RP. Instead, they spread to the bones, overstimulating osteoclasts and creating lytic lesions. Another cause of hypercalcemia is excess vitamin D, either through the diet or through supplements, which can cause too much calcium to be absorbed in the gut. There are also some medications, like thiazide diuretics, that increase calcium reabsorption in the distal tubule of the kidney, which contributes to hypercalcemia. Finally, hypercalcemia can be caused by familial hypocalciuric hypercalcemia. This is a genetic disorder caused by defective calcium-sensing receptors in the parathyroids and the kidney. These receptors are less sensitive to calcium levels in the blood, so the parathyroids might overproduce PTH. When the kidneys can't sense calcium levels, they will increase calcium reabsorption, leading to hypocalcemia and hypercalcemia. Now, you can remember symptoms of hypercalcemia with the mnemonic stones, bones, groans, thrones, and psychiatric overtones. For stones, it's important to know that the kidneys try to dump all that excess calcium into the urine, causing hypercalciuria. Hypercalcemia can also cause some form of resistance to the antidiuretic hormone, or ADH. This means that not enough water will be retained, and in turn, this leads to frequent urination, which can cause dehydration. Now, for your tests, remember that the combination of hypercalciuria and dehydration can lead to calcium oxalate kidney stones. For bones, in the case where there's bone resorption, we might also have bone pain. For thrones, voltage-gated sodium channels are less likely to open up, which makes it harder to reach depolarization and makes the neurons less excitable. The sluggish firing of neurons also leads to slower muscle contraction, which causes constipation, which in turn can cause abdominal pain. Finally, for psychiatric overtones, in the central nervous system, hypercalcemia can cause anxiety and altered mental status, since calcium also helps with releasing neurotransmitters from neurons. Alright, now with hypocalcemia, there's too little calcium in the ECF. This can be caused either by less calcium entering the blood or by too much calcium leaving the blood. For your exams, remember that less calcium entering the blood is the most common cause of hypocalcemia, and this can be due to hypoparathyroidism, which means lower levels or lower activity of parathyroid hormone. Hypoparathyroidism can be caused by surgical removal or autoimmune destruction of the parathyroid gland, by congenital problems involving the parathyroid gland, like DiGeorge syndrome, or by magnesium deficiency, since magnesium is needed for parathyroid hormone production. Low levels of vitamin D can also lead to hypocalcemia, and these can be caused by a deficient diet, malabsorption, cirrhosis, lack of sunlight, or chronic renal failure, among other causes. Then there's too much calcium leaving the blood. For example, in kidney failure, the nephron doesn't effectively reabsorb calcium, which means that calcium is excreted into the urine. Another cause of calcium leaving the blood is tissue injury, like burns, rhabdomyolysis, and tumor lysis syndrome, where large numbers of cells die and release intracellular phosphate into the blood. This phosphate binds to the ionized calcium and forms calcium phosphate, making the calcium insoluble and effectively decreasing the total amount of calcium in the blood. Other inflammatory processes can also cause too much calcium to leave the blood. For example, note that in acute pancreatitis, lipase that leaks out breaks down fat in the body. The free fatty acids end up binding to ionized calcium, making it insoluble and precipitating out as a soap-like substance. Finally, calcium levels can fall as a result of having too many blood transfusions. This is because additives to the blood, like citrate and ethylene diamine tetraacetic acid, or EDTA, can chelate or bind to calcium, forming calcium complexes, which are inactive molecules. With hypocalcemia, voltage-gated sodium channels are less stable and more likely to open up, which allows the cell to depolarize more easily and makes the neuron more excitable. This can trigger tetany, or the involuntary contraction of muscles, a classic symptom of hypocalcemia. The spontaneous firing of neurons also leads to Shavastic sign, which is when facial muscles twitch after the facial nerve is lightly finger-tapped 1 centimeter below the zygomatic process. It also can cause Trousseau's sign, which is where a blood pressure cuff putting pressure on the nerve is enough to make it fire, which results in a muscle spasm that makes the wrist and metacarpophalangeal joints flex. Now, calcium is also important for cardiac muscle contraction. The action potential in the cardiac muscle has 4 phases. In phase 2, the cardiac muscle tries to repolarize and get ready for another contraction by letting more calcium in the cardiac cells. Well, in hypocalcemia, it will take longer for the cardiac muscle to repolarize. Now we can see this on the ECG as a prolonged QT interval, since QT interval accounts for both ventricular depolarization and repolarization. Moving on to magnesium, which is another cation that acts as a cofactor in many enzymatic reactions, and also helps to maintain good nerve and muscle function, including the cardiac muscle. Magnesium also helps with strengthening the bones. In hypermagnesemia, there's too much magnesium in the ECF. This most commonly occurs when the kidneys cannot excrete magnesium properly, which can happen in renal failure. Another cause of hypermagnesemia is ingesting more magnesium than the kidneys can excrete. Sometimes this can be due to an intravenous infusion of magnesium that isn't prepared correctly. Other times it can be due to a magnesium-containing medication, like magnesium hydroxide, which can be used to treat symptoms like constipation and heartburn. With hypermagnesemia, there can be some serious complications. At the neuromuscular junction, there are voltage-gated calcium channels on presynaptic neurons that need to open and let calcium in to cause the neuron to release neurotransmitters and cause muscle contraction. Under normal circumstances, magnesium seems to inhibit calcium influx a little bit, which actually helps stabilize the axon. But with too much magnesium floating around, it tends to inhibit calcium influx even more, which interferes with neurotransmitter release and ultimately slows muscle contraction. So with hypermagnesemia, for your tests, remember that with hypermagnesemia, deep tendon reflexes might be decreased and lethargy can occur. Also, normally, PTH usually stimulates calcium release into the blood. Hypermagnesemia seems to inhibit the release of parathyroid hormone from the parathyroid gland, which causes calcium levels to fall, leading to hypocalcemia, which is usually transient and asymptomatic. Really high levels of magnesium also alter the electrical potential across the cardiac cell membrane, which can lead to bradycardia and even cardiac arrest. Now, with hypomagnesemia, there's too little magnesium in the ECF. This can be due to prolonged malnutrition where not enough magnesium is consumed. Alternatively, enough magnesium might be consumed, but it might not be absorbed in the gastrointestinal tract. This could happen because of interference from medications like proton pump inhibitors or from a bout of diarrhea. Another scenario that can lead to this is when the nephron fails to reabsorb the magnesium that's filtered out of the blood. This is commonly due to diuretics, particularly loop and thiazide diuretics, but can also result from Gitelman syndrome, where there's a mutation in the gene coding for the sodium chloride cotransporters in the distal tubule. This could change the electrochemical gradient and cause more magnesium to stick around in the lumen and then be peed out. The last commonly tested cause of hypomagnesemia is hungry bone syndrome, which is when the thyroid or parathyroid glands are surgically removed, leading to increased bone formation. In this case, the osteoblasts, or bone-forming cells, are literally hungry for ions to make more mineralized matrix, and they consume all the magnesium in the blood. Now, symptoms of hypomagnesemia are often neuromuscular. This happens because, under normal circumstances, at the neuromuscular junction, without magnesium floating around, calcium can enter neurons easily. This makes the muscles and nerves more excitable, meaning that a person can present with tetany. Severe hypomagnesemia can even lead to convulsions or seizures, as well as abnormal heart rhythms. On the ECG with hypomagnesemia, a form of ventricular tachycardia called torsade de pointes can occur. Additionally, hypomagnesemia is commonly associated with hypokalemia, partly because a lot of the conditions that cause hypomagnesemia, like diarrhea and diuretic therapy, are also responsible for hypokalemia. It's also thought that normally magnesium in the cells of the nephron tend to compete with potassium for potassium channels, so with less magnesium, more potassium is excreted in the urine. Finally, there's phosphate, which is an anion that's mostly located in the bone. Phosphate is also a component of nucleotides that make up DNA and RNA, high-energy molecules like adenosine triphosphate and metabolic intermediates. Phosphate also acts as a buffer for hydrogen. With hyperphosphatemia, there's too much phosphate in the ECF, and that can happen in a few different ways. The first possibility is a result of acute or chronic kidney disease, where the kidneys cannot excrete phosphate properly. Alright, so because parathyroid hormone causes excretion of phosphate and reabsorption of calcium, another cause of hyperphosphatemia is hypoparathyroidism, where the parathyroid glands don't produce enough parathyroid hormone in the first place, resulting in increased reabsorption of phosphate and decreased reabsorption of calcium. This can happen following a thyroid gland removal surgery when the parathyroids are accidentally taken out too, or after radiation treatment for cancer of the head and neck. Also, people with the genetic disease DeGeorge syndrome are also born with parathyroid glands that are too small and can't produce enough parathyroid hormone. Related to this is pseudo-hypoparathyroidism, which is where the kidneys don't respond to parathyroid hormone because of a genetic defect in the parathyroid hormone receptor. Alternatively, phosphate levels can rapidly increase in the blood from excessive intake of a phosphate-based laxative and absorption through the gastrointestinal tract or through the bloodstream via intravenous fluids. A final cause of hyperphosphatemia relates to the fact that most phosphate in the body is within the cells. Anytime a lot of cells die, that phosphate is spilled into the bloodstream, causing hyperphosphatemia. This cause includes things like crush injuries, tumor lysis syndrome, or rhabdomyolysis. Remember that this is classically accompanied by hyperkalemia. With hyperphosphatemia, the excess phosphate can stick to calcium, which forms bone-like crystals containing calcium and phosphate in places that they shouldn't be, like just beneath the skin, in the walls of blood vessels, in the joints. For your tests, remember that these are called metastatic calcifications. When calcium phosphate reach the kidneys, they can form kidney stones. Remember that since the phosphate binds to calcium in the ECF, another complication is hypocalcemia. Now, with hypophosphatemia, there's too little phosphate in the ECF. This can arise from excessive loss of phosphate, such as in conditions like primary hyperparathyroidism, where there's too much parathyroid hormone leading to more phosphate being excreted in the urine. Another example of this kind of condition is Fanconi syndrome, which is where the proximal convoluted tubule essentially loses its capacity to reabsorb a variety of solutes, including phosphate, which once again means that it's excreted in the urine. Another thing that can lead to hypophosphatemia is not absorbing enough phosphate through the gastrointestinal tract. Some substances, like alcohol, can impair phosphate absorption. Also, medications, including antacids that contain aluminum, calcium, or magnesium, all of which are positive ions, can bind with a negatively charged phosphate and prevent absorption. Alternatively, a person might not get enough phosphate in their diet, although this is unusual because it's found in nearly all foods. The exception is someone who's starving and severely malnourished, or someone who's actively depriving themselves of food, like in anorexia nervosa. Now, there's also something called refeeding syndrome. When a person is starved, blood glucose levels are low, and as a result, cellular metabolism slows down considerably. When an individual in this state starts to suddenly eat healthy meals again, like in a hospital setting, they suddenly have a bunch of glucose in their blood, and insulin usually skyrockets in response to this in order to push that newfound glucose into the cells. This causes a demand for phosphate in cells because the first step in glucose metabolism is to have the enzyme hexokinase attach phosphate to the glucose. Also, the production of ATP molecules themselves requires a lot of phosphate. The increase in metabolism also increases the uptake of other ions, so we also get hypokalemia and hypomagnesemia. Now, consequences of hyperphosphatemia include weak bones, osteomalacia in adults, and rickets in children, as well as bone loss. This happens over time due to prolonged hypophosphatemia because phosphate is an important component of the bone, and when there's not enough phosphate in the body, bone mineralization is decreased. Okay, as a quick recap, hyperkalemia presents with muscle weakness and palpitations, and the ECG shows wide QRS complexes and peaked T waves. Hypokalemia presents with muscle weakness, cramps and spasms, as well as palpitations, and the ECG shows flattened T waves and U waves. Hypernatremia can present with irritability, stupor, and coma, while hyponatremia presents with nausea, malaise, seizures, and stupor and coma. Hypercalcemia can lead to kidney stones, abdominal pain, bone pain, as well as increased urinary frequency, anxiety, and altered mental status. Hypocalcemia presents with tetany, positive Schwastik and Trousseau signs, and the ECG shows prolonged QT. Hypermagnesemia presents with lethargy, decreased deep tendon reflexes, hypotension, hypocalcemia, bradycardia, and even cardiac arrest, while hypomagnesemia presents with tetany, hypocalcemia, hypokalemia, and torsade de pointes. Finally, hyperphosphatemia can lead to hypocalcemia, kidney stones, and metastatic calcifications, while hypophosphatemia can lead to bone loss, osteomalacia in adults, and rickets in children. Back to our cases. Lab tests and ECG show that Karen has hyperkalemia that was probably due to digitalis. Her symptoms included muscle weakness and palpitations. Remember, the key findings on ECG are wide QRS and peaked T waves. While Carmen has hypocalcemia, which is causing the tetany. She also had a positive Schwastik sign on the clinical examination. Key finding on the ECG was a prolonged QT.
In the emergency department, 2 people are coming in. One of them is 68-year-old Randy, who has left flank pain and gross hematuria. On the physical examination, there's also a palpable mass in the left abdomen. Randy also has a history of heavy smoking for the past 40 years. The other person is 54-year-old Uriah, who came in because of painless hematuria. A while ago, Uriah took cyclophosphamide for a condition he had called Hodgkin's disease. Both individuals had an ultrasound done, which showed a mass in Randy's left kidney and a mass in Uriah's bladder. Okay, so Randy has a mass in his left kidney, Uriah has one in his bladder. Let's first talk about renal masses, which can develop in both adults and children. These masses may be either cysts or tumors. In turn, renal cysts can be either simple or complex, while tumors can be benign, like renal oncocytoma, or malignant, like renal cell carcinoma. Regarding masses of the urinary tract, the main concerns are transitional cell carcinoma and squamous carcinoma of the bladder. Now let's look at them one by one. Simple cysts are very common and account for most of renal masses. They are typically small and occur in adults with otherwise healthy kidneys. On an abdominal ultrasound, they are perfectly round and have a thin wall and are filled with fluid. This liquid is produced by the kidney. The ultrafiltrate is the plasma without proteins that results after the filtration process that happens in the glomeruli, specifically in Bowman's capsule. This makes simple cysts anechoic on ultrasound, since the fluid does not produce an echo and thus appears black. Usually, they're asymptomatic and are discovered incidentally during an ultrasound or a CT scan done for other reasons. On the other hand, complex cysts are larger than simple cysts. Additionally, on an ultrasound, they have thick, irregular walls and are multilocular, meaning they have septations within that separate the cyst cavity into compartments. Sometimes, complex cysts may even have a solid component within. Now, complex cysts are more likely to cause symptoms like flank pain, for example. They also have a higher chance of becoming malignant, and that's why, for your tests, remember that complex cysts require additional follow-up and even surgical removal. Alright, let's now talk about renal oncocytoma, which is a benign tumor that usually appears in adults. It originates from the intercalated cells of the collecting ducts. Macroscopically, the tumor appears as a circumscribed mass with a central scar. Microscopically, unlike RCC, a renal oncocytoma has large eosinophilic cells without perinuclear clearing. Individuals can present with painless hematuria, flank pain, and an abdominal mass. Most of these benign tumors are resected in order to rule out malignancies, like RCC. Moving on to renal cell carcinoma, or RCC, which is the most common renal malignancy. It usually appears in males between the ages of 50 to 70. Risk factors for RCC include smoking and obesity. It's associated with mutations that cause gene deletions on chromosome 3. These mutations can be sporadic or inherited as a part of von Hippel-Lindau syndrome, which is characterized by the formation of cysts and tumors in different parts of the body, like the kidneys and pancreas. Now, RCC originates from the proximal convoluted tubules epithelial cells. For your tests, remember that the most common type of RCC is a clear cell carcinoma, where the cancerous cells are polygonal and filled with lipids and carbohydrates. They appear clear on microscopy because the standard tissue fixation and staining techniques dissolve the lipids in glycogen, leaving clear empty spaces behind. Now, RCC can invade the renal vein, and if it invades the renal vein on the left side, it can lead to varicocele. This is because the venous drainage from the left testis travels through the left testicular vein and then through the left renal vein and finally in the inferior vena cava. So if RCC invades the left renal vein, then the venous drainage of the left testis is blocked, leading to a varicocele. Remember for your exams that this can never happen on the right side because the venous drainage from the right testis goes directly into the inferior vena cava. Now that we've got that covered, RCC can also invade the inferior vena cava via the renal veins, and through hematogenous spread, it can cause metastasis to the lungs and bones. RCC can be asymptomatic, but it can also present with the classic triad of flank pain, hematuria, and palpable masses. That's because if the tumor is big enough, it will compress the surrounding tissues, leading to flank pain and the palpable mass. This compression can also damage the kidney, causing hematuria. In more advanced stages, weight loss can also be present. Now, RCC can also be associated with signs and symptoms of a paraneoplastic syndrome. First, the tumor can secrete erythropoietin, and this will affect the bone marrow, making it produce more red blood cells, in which case there will be polycythemia. In other cases, the tumor can also secrete a PTH-related protein, which acts just like parathyroid hormone and which causes the bones to release more calcium, leading to hypercalcemia. It can also produce ACTH, which causes the adrenal glands to overproduce cortisol, and there will be signs of Cushing syndrome like moon facies, buffalo hump, and hypertension. Finally, it can also produce renin, which is normally produced by the kidneys. Renin further activates the renin-angiotensin-aldosterone system, leading to hypertension. Now, treatment of RCC mostly depends on whether metastasis has occurred. If the tumor is strictly localized in the kidneys, then surgery or ablation of the tumor can be done. If there's metastasis, however, then immunotherapy with aldesleukin or targeted therapy can be done in selected cases. But, unfortunately, RCC is resistant to chemo and radiation therapy. Now, let's focus on Wilms tumor, also called nephroblastoma. This is the most common malignancy of early childhood and appears between the ages of 2 and 4. The tumor contains embryonic glomerular structures, and it originates in the metanephric blastema, which is the embryologic structure from which the nephrons develop. It's associated with mutations of tumor suppressor genes WT1 and WT2 that are located on chromosome 11. It presents with a large, palpable, unilateral flank mass and sometimes even hematuria. Wilms tumor can be a part of several syndromes. If there's WT1 deletion, then we get Wager syndrome, where W stands for Wilms tumor, A for aniridia, meaning the lack of iris, G for genitourinary anomalies like ambiguous genitalia, and R, which is the outdated term for mental retardation, which is now called intellectual disability. WT1 mutation is also associated with Denys-Strash syndrome, which is a triad of Wilms tumor, diffuse mesangial sclerosis with early onset nephrotic syndrome, and dysgenesis of gonads or male pseudohermaphroditism. WT2 mutation is associated with Beckwith-Weidman syndrome, which is a pediatric overgrowth syndrome, where there's Wilms tumor, organomegaly, macroglossia or enlarged tongue, and hemihyperplasia, where structures on one side of the body are larger than the other. Okay, we're done with renal masses. Let's move on to urinary tract carcinomas. Let's begin with transitional cell carcinoma. This is also known as urothelial carcinoma, because it originates in the epithelium that lines the organs of the urinary system. Because of this, transitional cell carcinoma can occur in the renal calyces, renal pelvis, or in the ureters, but it's most commonly found in the bladder. Risk factors include smoking, the use of cyclophosphamide, the use of aniline dyes, which is a compound that was found in hair coloring products, and finally, the use of phenacetin, which is an analgesic that's no longer used. One important symptom of transitional cell carcinoma that's commonly tested is painless hematuria. Also, because hematuria in this case comes from the urinary tract and not from the kidney, on microscopy there will be no casts in the urine. An abdominal and pelvic CT scan can also be used to locate the tumor, as well as determining how much the tumor has invaded and if there is any metastasis. A cystoscopy can be done where a thin tube containing a camera is inserted through the urethra to allow visualization of the bladder, and also to take a biopsy of the tumor. Finally, there's squamous cell carcinoma of the bladder, which is also derived from the urothelium. It's associated with chronic irritation of the bladder. See, the bladder is lined up with multiple layers of epithelial cells that form a so-called transitional epithelium, which can contract and expand depending on how full the bladder is. Now, irritation in the bladder can damage these cells and eventually lead to metaplasia, which is when the normal cells of a certain tissue convert to another type of normal cells usually found elsewhere in the body. And in this case, the epithelial cells lining the bladder, which are typically cuboidal or columnar, become squamous cells, which are normally found in the skin. Now, metaplasia can further lead to dysplasia, where the cells become completely different from any normal cells in the body, and this eventually leads to the development of squamous cell carcinoma. Risk factors include infection with schistosoma hematobium, a type of urinary blood fluke common in the Middle East, chronic cystitis, smoking, and chronic nephrolithiasis. All of these factors irritate the bladder and damage the cells lining it. For your tests, remember that squamous cell carcinoma of the bladder also can present with painless hematuria. A cystoscopy and an abdominal pelvic CT scan can also be done. Okay, let's review. Renal masses include simple cysts that are basically tiny balloons filled with black fluid on an ultrasound and don't give any symptoms. Or complex cysts, which on ultrasound have septations within and need follow-up because they can be malignant. Then there's a benign tumor called renal oncocytoma, where on microscopy the cells are eosinophilic and there's no perinuclear clearing. Next, there's renal cell carcinoma, which is the most common type of renal cancer and appears in males aged between 50 and 70. Other risk factors include smoking and obesity. Symptoms include palpable masses, flank pain, hematuria, weight loss, and even fever. On microscopy, the most common type of RCC is a clear cell carcinoma. Finally, there's Wilms tumor, which typically appears in early childhood and can be a part of several syndromes, like Wager syndrome, Denise-Drash syndrome, or Beckwith-Weidman syndrome. Urinary tract carcinomas include transitional cell carcinoma, which is the most common tumor of the urinary tract, and can present with painless hematuria. Then, there's squamous cell carcinoma of the bladder, which appears as a result of the chronic irritation of the bladder. Now back to our cases. Randy came in with left flank pain and gross hematuria, and there was also a palpable mass in his abdomen. The ultrasound showed a mass in his left kidney. Now, considering his age and the fact that he is also a smoker, it's likely that Randy has renal cell carcinoma. But first, a CT scan of the abdomen and the chest should be done to detect any tumors and metastasis. If a tumor is found, a biopsy of the mass might need to be done before confirming the diagnosis and starting treatment. Then there's Uriah, who presents with painless hematuria and who seems to have a mass in his bladder. Now, considering that Uriah at some point was treated with cyclophosphamide, he most likely has transitional cell carcinoma. But further investigations are needed, such as cystoscopy and a CT scan of the pelvis and abdomen.
In the emergency department, 2 people came in. One of them is 40-year-old Sarah, who came in with rapid, shallow breathing and tachycardia. The other one is 35-year-old Alfred, who came in with slow and shallow breathing. An arterial blood gas was taken, along with electrolytes. Results showed that Sarah had low blood pH, bicarbonate, and partial pressure of carbon dioxide levels, and her potassium level was also low. Alfred had a high pH, bicarbonate, and partial pressure of carbon dioxide levels, but his potassium level was low. Based on these results, Sarah was diagnosed with metabolic acidosis, while Alfred had metabolic alkalosis. Further investigations were done, like electrolytes and urinalysis. This showed that Sarah had hypophosphatemia, and urinalysis showed phosphaturia, aminoaciduria, and glucosuria, while Fred had hypokalemia, and urinalysis showed hypercalciuria. Now, the results from the labs of both individuals point towards some kind of renal tubular defect that's causing acid-base disorders. Before talking specifics, let's remember the physiology of the renal tubules. The proximal convoluted tubule, or PCT, reabsorbs bicarbonate, all glucose, uric acid, and amino acids. Apart from this, it also reabsorbs water, potassium, chloride, phosphate, and most of the sodium, as well as most of the calcium. The PCT also secretes hydrogen and phosphate into the urine. The thin descending loop of Henle reabsorbs water, and that's pretty much it. The thick ascending loop of Henle, or TAL, on the other hand, reabsorbs potassium, chloride, and sodium. Now, in order to reabsorb sodium, potassium, and chloride, there's a sodium-potassium chloride cotransporter, or NKCC2, that's only found in the kidney, and its role is to snatch these ions from the urine and reabsorb them. Apart from this, the thick ascending loop of Henle can also reabsorb calcium and most of the magnesium, but does not reabsorb water. Now, the distal convoluted tubule, or DCT, reabsorbs sodium and chloride through a sodium chloride cotransporter, as well as calcium and submagnesium. Again, it does not reabsorb water. Finally, the collecting tubule is regulated by aldosterone and reabsorbs sodium in exchange for potassium and hydrogen. Now, aldosterone acts on mineralocorticoid receptors and in the principal cells of the collecting tubule, which leads to potassium secretion, while in the alpha intercalated cells, this leads to hydrogen secretion. Alright, so now let's talk about tubular defects, which are a group of disorders that affect the renal tubules. Tubular defects are usually genetic, but they can also be acquired. The proximal convoluted tubule can be affected by Fanconi syndrome. The thick ascending loop of Henle can be affected by Bartter syndrome, while the distal convoluted tubule can be affected by Gittleman syndrome. The collecting tubule can be affected by Little syndrome. Finally, there's syndrome of apparent mineralocorticoid excess, or SAME, which also affects the collecting tubule. Let's start talking about Fanconi syndrome, which is a generalized reabsorption defect in the proximal convoluted tubule. Now, Fanconi syndrome can be hereditary or acquired. Hereditary Fanconi syndrome can be caused by inherited disorders like Wilson's disease. With this disease, there's a defect in the copper transporting protein, and this leads to accumulation of copper in various tissues. It primarily affects the liver, but other organs like the brain, cornea, and the kidney's proximal convoluted tubule are also affected. The latter can lead to Fanconi syndrome. Another example is tyrosinemia, which is caused by mutations in some enzymes needed for tyrosine metabolism. There are several mutations involved, but the key fact is that depending on where the tyrosine metabolism is affected, this can result in the accumulation of tyrosine or its byproducts in different organs, like the liver, kidneys, and peripheral nerves. Now, all that tyrosine or byproduct accumulation is toxic for the proximal tubule, and this can result in Fanconi syndrome. Finally, there's glycogen storage disease, which is a group of genetic conditions that affect either glycogen synthesis or the breakdown of glycogen or glucose. There are several mutations involved, but when glycogen metabolism is affected, this can result in the accumulation of glycogen in the liver and kidneys. Just like with tyrosinemia, all that glycogen can be toxic to the proximal convoluted tubule and result in Fanconi syndrome. Alright, next there's acquired Fanconi syndrome that can happen with ischemia. Now, renal ischemia has a lot of causes, like hypovolemia, which in turn also has a lot of causes, like diarrhea or acute hemorrhage. Now, hypovolemia leads to less blood flow to the kidneys, and this means that the cells are not getting all the blood supply and nutrients they need, and this can damage the proximal convoluted tubule, leading to Fanconi syndrome. Another condition is multiple myeloma, which can cause proximal tubular dysfunction. Now, multiple myeloma is a monoclonal gammopathy, where there's a proliferation of plasma cells in the bone marrow. These plasma cells secrete many abnormal immunoglobulins, which are then filtered in the kidneys and are pretty toxic for the proximal tubule, and as a result, this can lead to Fanconi syndrome. Then there are nephrotoxic drugs, like ifosfamide, cisplatin, or expired tetracycline, and heavy metal exposure, like lead poisoning that can damage the proximal convoluted tubule. Alright, now since the entire proximal tubule is damaged, it won't be able to reabsorb things like bicarbonate, sodium, glucose, phosphate, uric acid, etc., and they're lost in the urine. Now, when bicarbonate is not reabsorbed in the proximal tubule, it can lead to proximal renal tubular acidosis, or type 2 renal tubular acidosis, also known as type 2 RTA. Here, a lot of bicarbonate is lost in the urine, and as a result, serum bicarbonate levels fall, leading to acidemia and metabolic acidosis. Another important fact to remember is that since phosphate is lost in the urine, there's also hypophosphatemia, which in turn decreases bone mineralization, so these people often suffer from osteopenia. Next, let's move on to the loop of Henle and look at Bartter syndrome, which is an autosomal recessive condition. This is a defect that causes a mutation in the NK-CC2 cotransporter in the thick ascending loop of Henle, leading to a loss of sodium, potassium, and chloride in the urine. Even though there's more sodium lost through the urine, more water is lost with it, so typically there's no hyponatremia. However, the potassium lost through the urine will lead to hypokalemia. Also, in the thick ascending loop of Henle, calcium is reabsorbed with the help of an electrochemical gradient that's created by the movement of sodium, chloride, and potassium. Another high-yield fact to remember is that when these ions are lost, calcium also cannot be reabsorbed, leading to hypercalciuria. Now, the loss of all these ions in the urine causes volume contraction or excessive loss of extracellular volume. This in turn triggers the renin-angiotensin-aldosterone system. As a result, angiotensin II and aldosterone levels rise, and the kidneys start to secrete more potassium and hydrogen ions while reabsorbing more bicarbonate in the proximal convoluted tubule, and serum bicarbonate levels rise, leading to metabolic alkalosis. Alright, for your exam, a high-yield fact is that loop diuretics also block the NK-CC2 cotransporter in the thick ascending loop of Henle, which means that Bartter syndrome presents almost like chronic loop diuretic use. Okay, let's continue our journey through the tubules and stop in the distal convoluted tubule. Here we have another autosomal recessive condition called Gittleman syndrome. This is a defect that causes a mutation in the sodium chloride cotransporter in the distal convoluted tubule, and this affects the reabsorption of sodium chloride. The loss of sodium chloride leads to the loss of water, which results in mild volume contraction. Just like in Bartter syndrome, this activates the renin-angiotensin-aldosterone system, which in turn leads to increased excretion of potassium, causing hypokalemia, and hydrogen, resulting in metabolic alkalosis. Now, volume contraction can also increase calcium reabsorption, and this leads to hypocalciuria. That's because in the proximal convoluted tubule, studies suggest that calcium reabsorption is secondary to sodium and water reabsorption, but the exact mechanism here is still not clear. So when there's volume contraction, sodium and water reabsorption increases in the proximal convoluted tubule to compensate the losses. And as a result, calcium reabsorption also increases. Additionally, Gittleman syndrome also decreases magnesium reabsorption. Alright, so in the distal convoluted tubule, there's a protein that acts as a channel, and that allows some magnesium reabsorption. It's thought that Gittleman syndrome also causes a mutation in the gene that makes this protein, and as a result, there'll be magnesium wasting in the kidneys, which in turn causes hypomagnesemia. Okay, remember that thiazide diuretics also block sodium chloride reabsorption in the distal convoluted tubule. So on your test, a person with Gittleman syndrome will present similarly as someone on thiazide diuretics. Alright, moving on to the collecting tubule, where this time we have an autosomal dominant condition called Little syndrome. Now, this defect causes a mutation in the sodium channel in the collecting tubule that increases their activity, so more sodium is reabsorbed. A key concept is that aldosterone also increases the activity of these channels, so Little syndrome clinically presents as hyperaldosteronism, with symptoms like high blood pressure, headaches, and fatigue. You can differentiate between the two by looking at the aldosterone levels, which are typically very low, or even absent in people with Little syndrome. Now, normally, aldosterone induces the synthesis of more sodium channels in the distal and collecting duct cells. This allows for more sodium to enter the cells, so there's more sodium available for the sodium-potassium ATPase, found on the basolateral surface of the tubular cells. The sodium-potassium ATPase gets 2 potassium ions inside the cells, and pumps 3 sodium ions outside the cells. As a result, sodium is pumped out of the cells and eventually into the bloodstream, while potassium enters the cells. In this way, the intracellular potassium concentration increases, and this creates a driving force for potassium to be secreted from the cell into the lumen. Now, with Little syndrome, basically the same thing happens, but unlike the renin-angiotensin-aldosterone system, there's nothing that stops the sodium channel from reabsorbing all that sodium and excreting all that potassium. As a result, a lot of sodium is reabsorbed and a lot of potassium is lost, and this will lead to hypertension and hypokalemia. Now, the kidneys will try to compensate the loss of potassium by increasing the activity of potassium-hydrogen ATPase in the collecting tubule. This will reabsorb potassium and will secrete hydrogen ions in the collecting tubule. As a result, the loss of hydrogen ions will lead to metabolic alkalosis. In order to stop or slow down the sodium channel, a potassium-sparing diuretic, specifically amiloride, is given to block this channel. Finally, there's syndrome of apparent mineralocorticoid excess, or SAME. This can be hereditary and transmitted in an autosomal recessive pattern or acquired. With hereditary SAME, there's 11-beta-hydroxysteroid dehydrogenase deficiency. Normally, aldosterone is the main hormone that binds to the mineralocorticoid receptor in the kidneys. However, cortisol can also bind to mineralocorticoid receptors. But the enzyme 11-beta-hydroxysteroid dehydrogenase in the collecting tubules metabolize cortisol to cortisone, which cannot bind to these receptors. In SAME, there's a decrease in the level of these enzymes, so cortisol levels increase and overactivate these receptors. A high yield fact to remember is that this will basically mimic the effects of aldosterone. So serum aldosterone levels are low, but there are symptoms of hyperaldosteronism. Just like Little syndrome, a lot of sodium is reabsorbed, leading to hypertension, and a lot of potassium is lost, leading to hypokalemia. The kidneys will try to compensate for the potassium losses using the potassium hydrogen ion ATPase to reabsorb potassium and secrete hydrogen, leading to metabolic alkalosis. Interestingly enough, a person can also get SAME by eating too much licorice. That's because licorice contains a lot of glycerinic acid that can inhibit 11-beta hydroxysteroid dehydrogenase, leading to the disease. The treatment of SAME relies on giving potassium-sparing diuretics in order to lower the mineralocorticoid effects, like hypokalemia. Another option is giving corticosteroids, because exogenous corticosteroids lower the endogenous production of cortisol, meaning that not so much cortisol will bind to the mineralocorticoid receptor. Alright, as a quick recap, Fanconi syndrome is a proximal convoluted tubule dysfunction where there's increased excretion of all substances normally reabsorbed by the proximal convoluted tubule, like glucose, bicarbonate, and so on. As a result, there's metabolic acidosis, type 2 renal tubular acidosis, hypophosphatemia, and sometimes even osteopenia. Bartter syndrome is an autosomal recessive disorder that affects the sodium-potassium chloride cotransporter in the thick ascending loop of Henle, leading to metabolic alkalosis, hypokalemia, and hypercalciuria, and it presents similarly to chronic loop diuretic use. Gittleman syndrome is another autosomal recessive disorder that affects reabsorption of sodium chloride in the distal convoluted tubule, leading to metabolic alkalosis, hypomagnesemia, hypokalemia, and hypocalciuria, and it presents similarly to chronic thiazide diuretic use. Then there's Little syndrome, which is an autosomal dominant disorder where there's increased sodium reabsorption in the collecting tubules, leading to metabolic alkalosis, hypokalemia, hypertension, and low levels of aldosterone. Treatment here relies on amiloride. Finally, there's SAME, where there's 11-beta hydroxysteroid dehydrogenase deficiency, and as a result, cortisol binds to the mineralocorticoid receptor, leading to metabolic alkalosis, hypokalemia, and hypertension. Treatment relies on potassium-sparing diuretics or corticosteroids. Alright, coming back to our cases. Sarah came in hyperventilating and lab tests showed that she had metabolic acidosis and hypophosphatemia, and urinalysis showed phosphaturia, amino acid uria, and glucoseuria, which indicates Fanconi syndrome. On the other hand, Alfred came in hypoventilating, and lab tests showed that he had metabolic alkalosis and hypokalemia. Urinalysis showed hypercalciuria, indicating Bartter syndrome. Urinary tract infections, or UTIs, are infections that affect part of the urinary tract. They're usually caused by bacteria found in fecal flora, which normally colonizes the urethral meatus. However, when those bacteria make their way up the urethra and into the bladder, they can cause lower UTIs, like cystitis, which is the inflammation of the bladder, or upper UTIs, like acute pyelonephritis, which is the inflammation of the renal pelvis and kidneys. Both cystitis and acute pyelonephritis can be uncomplicated or complicated. By complicated, we mean that the individual has an associated structural or functional condition of the genitourinary tract, or an underlying disease which increases the risk of a severe infection. So a complicated UTI is one that happens in a male, a pregnant female, and individuals with indwelling urinary catheters. Additionally, it's considered a complicated UTI when it happens in individuals with poorly controlled diabetes mellitus, immunocompromised individuals, those with urologic conditions like urethral strictures, and those that have had urologic procedures. So let's start with uncomplicated cystitis. The most common pathogens are Enterobacteriaceae, which include Escherichia coli, Klebsiella pneumoniae, and Proteus mirabilis. Another pathogen is Staphylococcus saprophyticus. Uncomplicated cystitis usually appears in women because they have a shorter urethra than men. making the urethral meatus closer to the anal orifice. Risk factors for cystitis are recent sexual intercourse, as well as the use of spermicide-coated condoms, or general spermicides, because spermicides facilitate the growth of E. coli. Shortly after sexual intercourse, symptoms include dysuria, urinary frequency, urinary urgency, and suprapubic pain. In females over 65 years, symptoms can include chronic dysuria or urinary incontinence. Now, in young women with typical symptoms, no further testing is necessary to make the diagnosis. But in individuals with atypical symptoms, a urinalysis is done, either by dipstick or microscopy, along with urine cultures and susceptibility testing. On the dipstick, a positive leukocyte esterase suggests pyuria, and positive nitrites reflects the presence of Enterobacteriaceae, which converts urinary nitrate into nitrite. On microscopy, there are usually over 10 leukocytes per microliter, and over 5 red blood cells per microliter. A gram stain is also done in order to rapidly identify some bacteria, like E. coli. Now, ideally, the urine sample shows the bladder bacterial count with very little contamination from the distal urethra and genital mucosa. This is obtained by a clean catch, midstream sample of the first urine of the day. The urine culture shows bacteriuria, meaning more than 1,000 or 10 to the third power colony-forming units, or CFUs, per milliliter of the predominant species, usually a known pathogen. If it's lower than 1,000 CFU per milliliter, then it's considered contamination. A similar cutoff is used for a urine sample taken from an individual with an indwelling urinary catheter. If the urine sample was taken through suprapubic aspiration, then any amount of bacteria present, no matter what the number is considered diagnostic for an infection. That's because the urine in the bladder is normally sterile and shouldn't contain any bacteria. Treatment of uncomplicated cystitis relies on antibiotics and medication to help with urinary discomfort. Antibiotic therapy is usually done empirically without urine culture and susceptibility testing, and common choices are 100 milligrams of nitrofurantoin twice daily for 5 days, or a single double strength of trimethoprim sulfamethoxazole tablet, or 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole twice daily for 3 days, both given orally. Alternatively, 3 grams of phosphomycin can be given orally in a single dose. Follow-up cultures are not needed if symptoms resolve on antibiotic therapy. However, if individuals have persistent symptoms after 72 hours of antibiotics or recurrent symptoms within a few weeks of the initial treatment, then urine cultures and susceptibility testing is done and empiric treatment is started with another antibiotic. When results are available, antibiotic treatment is adjusted accordingly. Pain management is done with phenazopyridine for 3 days. This is a drug that's excreted in the urine and has a local analgesic effect, which helps relieve dysuria. Alright, so moving on to uncomplicated pyelonephritis, which is typically caused by the ascension of bacteria via the urethra and into the bladder, ureter, and the kidneys, but can also be caused by bacteremia, causing an infection in the kidneys. Symptoms develop quickly, and the individual typically has a fever, costovertebral angular tenderness, nausea, and vomiting, in addition to symptoms of cystitis. Lab studies include a CBC, which typically shows leukocytosis with neutrophilia. Renal function can be checked by obtaining a BUN and creatinine level. Urinalysis is done using either dipstick or microscopy. On microscopy, if there are white cell casts that take the form of the renal tubules, then it suggests that there's a renal origin for pyuria. That's because where there's an infection in the renal pelvis, there are also leukocytes, and they tend to aggregate and take the form of the renal tubules as they pass through. Finally, urine culture and susceptibility testing is always done. On a renal ultrasound, pyelonephritis shows up as a hypoechoic mass within one kidney, but it can also be bilateral. Now, sometimes imaging is needed with an abdominal CT scan with or without contrast. For example, imaging is useful in individuals who still have symptoms after 72 hours of antibiotic treatment. On a CT scan, acute pyelonephritis shows localized hypodense regions in one or both kidneys. Imaging should also be done if we suspect a urinary obstruction, like a stone, which can cause a decline in urine output and cause elevated creatinine levels. A CT scan can help identify a stone's location as well as signs of hydronephrosis, which often happens as a result of the obstruction. Alright, now empiric treatment can be started with oral ciprofloxacin for 7 days in individuals that can tolerate oral treatment. In individuals with nausea or vomiting, IV ciprofloxacin or IV ceftriaxone can be used for 10 to 14 days. IV antibiotics can be switched to oral antibiotics if symptoms improve. In individuals with urinary obstruction, broad-spectrum antibiotics like IV imipenem plus IV vancomycin are given for about 14 days. The antibiotic treatment is then adjusted according to the results of urine culture and susceptibility testing. Now let's switch to complicated UTIs. In both complicated cystitis or complicated pyelonephritis, a urinalysis, urine culture, and susceptibility testing is always done, because the pathogen is more likely to be an atypical bacteria. In pregnancy, cystitis is treated with oral cefpodoxime or amoxicillin clavulinate for 3 to 7 days, or oral fosfomycin in a single dose. Oral nitrofurantoin can also be used. Acute pyelonephritis in pregnant women is treated with IV ceftriaxone or IV cefazolin until the female is afebrile. Once afebrile for 48 hours, pregnant females are switched to oral therapy according to the results of the urine culture and susceptibility test. Options include oral cefepime. Oral trimethoprim sulfamethoxazole can be used during the second trimester. The duration of the oral antibiotic treatment is 10 days. In males, treatment of cystitis includes oral trimethoprim sulfamethoxazole for at least 7 days. Now, if cystitis in males doesn't respond to antibiotic treatment, then the individual should be further evaluated in order to diagnose an underlying urologic condition, like a ureteral stricture. With acute pyelonephritis in men, prostatitis, or the inflammation of the prostate, might be also associated, and since symptoms of prostatitis are similar to those of acute pyelonephritis, it can be easily missed. In this situation, a serum PSA level is useful, because with prostatitis, PSA is elevated. Treatment of acute pyelonephritis in men includes oral ciprofloxacin or cefotaxime for 2 weeks. Now, a catheter-associated UTI happens in an individual that's currently catheterized or has been catheterized in the past 48 hours. Before starting any antibiotic treatment, the catheter should be removed or replaced. If the individual is not severely ill, then oral levofloxacin can be given for 5 days. If the individual has systemic symptoms, like a fever, then IV ceftriaxone or IV amoxicillin plus gentamicin can be given for 14 days. Now, there's also asymptomatic bacteriuria, which is the presence of bacteria in the urine without any symptoms. This is usually discovered incidentally, during a routine urine culture or in pregnant women that are screened for bacteriuria. Urine culture shows at least 10 to the 5th power colony-forming units, or CFUs, per milliliter of a known pathogen, like E. coli. A single urine culture is sufficient for males, whereas for females, 2 urine cultures showing the same results are needed. Now, asymptomatic bacteriuria is only treated in certain situations like pregnancy, renal transplant recipients, and individuals who are about to have a urologic intervention, like transurethral resection of the prostate. In pregnancy, treatment is done with oral amoxicillin clavulinate or nitrofurantoin for 7 days, or a single dose of oral fosfomycin. In renal transplant recipients, antibiotic therapy includes oral ciprofloxacin, amoxicillin, or nitrofurantoin for 5 days and afterwards. Treatment can be then adjusted according to urine culture and susceptibility testing. Regarding those about to have a urologic intervention, IV ciprofloxacin is given 2 hours prior to the intervention. Finally, there are renal and perinephric abscesses. A renal abscess is a collection of pus in the kidneys, while a perinephric abscess is a collection of pus that's around the kidneys, between the renal capsule and gyrandus fascia, which is a layer of tissue that surrounds the kidney and the adjacent adrenal gland. Both can happen as a result of an ascending infection from a UTI or due to bacteremia, especially with Staphylococcus aureus. Risk factors for developing abscesses include diabetes mellitus, pregnancy, and urinary tract abnormalities, like vesicoureteral reflux, kidney stones, or polycystic kidney disease. Symptoms develop over weeks and include a fever, back or abdominal pain, fatigue, and even weight loss. There's also usually costovertebral angle tenderness. Lab studies include a CBC, which shows leukocytosis. In addition, CRP and ESR are elevated. Urinalysis shows pyuria if the abscess communicated with the collecting system, moderate proteinuria, and bacteriuria. Additionally, blood cultures are done to identify the culprit. Imaging includes plain radiography, which might show scoliosis with the concavity toward the abscess. And that's because the psoas muscle on the affected side gets irritated and pushes the spine away. Additionally, an abdominal mass or an enlarged kidney that has an irregular margin can be seen. On the ultrasound, there's a thickened, walled-off cavity that's full of fluid. On an abdominal CT scan, a renal abscess is seen as an intrarenal walled-off cavity, and a paranephric abscess is a collection in the paranephric space. Empiric treatment of renal and paranephric abscess is IV piperacillin tazobactam, or IV cefepime, or ticarcillin clavulinate for 3 weeks. Once the results of urine cultures and susceptibility testing are available, the treatment is adjusted accordingly. When a renal abscess is larger than 5 centimeters, and when a paranephric abscess is larger than 3 centimeters, percutaneous drainage of the abscess is done in addition to antibiotic therapy. If the paranephric abscess has a lot of septations within and can't be drained, then surgery is recommended. Alright, as a quick recap. In a young woman with typical symptoms of uncomplicated cystitis like dysuria, urinary frequency, urinary urgency, and suprapubic pain, no further workup is needed. Empiric antibiotic treatment includes 100 milligrams of nitrofurantoin twice daily for 5 days, or a single double strength of trimethoprim sulfamethoxazole tablet, or 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole twice daily for 3 days, both given orally, along with phenazopyridine for 3 days to relieve dysuria. In women with atypical symptoms, a urinalysis and urine culture and susceptibilities are done for diagnosis. Uncomplicated acute pyelonephritis presents with fever, costovertebral angle tenderness, nausea, and vomiting. Lab studies include a CBC showing leukocytosis, BUN, creatinine, urinalysis, which shows pyuria, urine culture, and susceptibilities. Antibiotic therapy includes oral ciprofloxacin for 7 days, or IV ciprofloxacin or IV ceftriaxone for 10 to 14 days for individuals that don't tolerate oral treatment. Complicated UTIs are those where the individual is at risk for developing a severe infection, and in this case, urine cultures and susceptibility testing is always done. In pregnancy, cystitis is treated with oral cefprioxime or amoxicillin clavulinate for 3 to 7 days, or oral fosfomycin in a single dose, and acute pyelonephritis with IM ceftriaxone or IV cefazolin. If the pregnant female remains afebrile for 48 hours, oral cefepime is given for 10 days. In men, cystitis is treated with oral trimethoprim sulfamethoxazole for 7 days, and acute pyelonephritis with oral ciprofloxacin or oral cefotaxime for 2 weeks. Asymptomatic bacteriuria is the presence of more than 10 to the 5th power CFUs per milliliter in the absence of any symptom. It requires treatment in pregnancy, with oral nitrofurantoin for 3 to 7 days or a single dose of oral fosfomycin. Renal transplant recipient with oral ciprofloxacin, amoxicillin, or nitrofurantoin, or in those about to have a urologic intervention with ciprofloxacin or trimethoprim sulfamethoxazole. With a renal and paranephric abscess, imaging is done using plain radiography, ultrasound, and an abdominal CT with contrast. Empiric antibiotics include IV piperacillin tazobactam or IV cefepime, and usually last for 3 weeks. When a renal abscess is larger than 5 centimeters, and when a paranephric abscess is larger than 3 centimeters, percutaneous drainage of the abscess is done. Two people came to the nephrology ward. The first one is 25-year-old Carmen, who recently returned from her honeymoon and now complains of suprapubic pain, dysuria, and urinary frequency. The other one is 35-year-old Pamela, who has had dysuria, fever, nausea, and flank pain for the past 2 days. On physical exam, she has costovertebral angle tenderness. CBC and urinalysis were done for both people. They showed that Carmen had a normal white blood cell count, but on the dipstick test, leukocyte esterase and nitrites were both positive. For Pamela, the white blood cell count was high. The dipstick test showed positive leukocyte esterase and nitrites. And on microscopy, there's white blood cell casts in the urine. Both Pamela and Carmen have urinary tract infections, or UTIs. This includes the lower portion of the tract, like the bladder and urethra, and the upper portion of the tract, like the kidneys and ureters. UTIs are almost always caused by an ascending infection, where bacteria moves from the rectal area to the urethra and then migrate up the urethra and into the bladder. Normally, bacteria would be washed away with urination, but in some cases, like with E. coli, that does not happen. Instead, E. coli uses little thread-like extensions called fimbriae to bind to the uroepithelial cells and colonize the bladder mucosa, causing cystitis. From the bladder, the infection can go up the ureter and into the kidney, where they attract neutrophils into the renal interstitium, causing pyelonephritis. As the neutrophils die off, they make their way through the urinary tract and appear in the urine. The neutrophils and the surrounding inflammatory protein debris is even casted into the shape of the tubule, creating white blood cell casts and hyaline casts. For your exams, remember that the other factors like sexual intercourse or an indwelling catheter can also let bacteria into the urinary tract. So remember, in ascending infections, bacteria moves from the rectal area to the urethra, and then migrate up the urethra and into the bladder. In most cases, ascending infections are caused by Escherichia coli, but other bacteria like Staphylococcus saprophyticus, Klebsiella pneumoniae, or Proteus mirabilis can also cause ascending infections. Now, descending infections are also possible in rare cases. This is when the kidneys get infected via hematogenous infection, or spread through the bloodstream. In this case, acute pyelonephritis can be a consequence of septicemia or bacteremia. In these situations, the most common organisms are Staphylococcus species and again E. coli. Alright, so now let's talk about cystitis. There are some risk factors associated with cystitis. It's more common in female individuals because they have a shorter urethra, which makes it easier for the bacteria to ascend because the urethra is closer to the rectum, where the primary culprits live. Another risk factor is frequent sexual intercourse, which can lead to honeymoon cystitis, especially in younger female individuals. Remember, this type of infection is often caused by Staphylococcus saprophyticus. Other risk factors include diabetes mellitus, indwelling catheter, and impaired bladder emptying, which can happen when there's a bladder tumor, for example. Symptoms include dysuria, which is painful urination, urinary frequency and urgency, and suprapubic pain. CBC, urinalysis, and urine cultures are done to confirm the diagnosis and find the culprit. On CBC, the white blood cell count is normal. The appearance of the urine is often cloudy, and the dipstick test shows positive leukocyte esterase, which signifies pyuria, or the presence of white blood cells in the urine. Dipstick also shows positive nitrites, and this is caused by Enterobacteriaceae, like E. coli, Proteus, and Klebsiella, converting normal urine nitrates into nitrites. On microscopy, there are more than 10 white blood cells per high-power field. The best way to identify the organism for treatment is to do a urine culture. Now, sometimes cystitis can be mistaken for urethritis, which is inflammation of the urethra. Urethritis can present with the same symptoms as cystitis, but the difference is that urethritis is most commonly caused by Neisseria gonorrhoeae, as well as Chlamydia trachomatis. Both of these are sexually transmitted infections. With both, urinalysis shows sterile pyuria, meaning that leukocyte esterase is positive, but when cultures are done, no bacteria are found. Moving on to acute pyelonephritis. Risk factors include indwelling catheters, diabetes mellitus, and pregnancy. Another risk factor is any obstruction in the urinary tract, like kidney stones. This causes urinary stasis, making it easier for bacteria to adhere to and colonize the tissue. Now, another major factor is vesicoureteral reflux, or VUR. This is where the one-way valve at the vesicoureteral junction is loose, which allows the urine to move from the bladder back into the ureters and kidneys. VUR can be the result of a primary congenital defect, or it can be caused by bladder outlet obstruction, like a bladder tumor, which increases pressure in the bladder and distorts the valve. For symptoms, people with acute pyelonephritis can have a similar presentation as cystitis, where they have dysuria, urinary frequency, and urinary urgency. The person might have flank pain, implying there's something going on with the kidneys. The distinguishing feature for pyelonephritis is that there are systemic symptoms, like fever, chills, nausea, or vomiting. On clinical examination, there'll be costovertebral angle tenderness. A CBC, urinalysis, and urine cultures are done. The urinalysis is positive for leukocyte esterase and nitrites, like cystitis, but white blood cell and hyaline casts are sometimes present. On the CBC, the white blood cell count is high, and this will help you differentiate between cystitis and pyelonephritis. Now remember, imaging methods are not necessary for diagnosis. CT could show striated parenchymal enhancement, also known as striated nephrogram. Now, recurrent episodes of acute pyelonephritis can result in chronic pyelonephritis, where the renal interstitium undergoes fibrosis and scarring, leading to tubule atrophy. These changes are generally found in the upper and lower poles of the kidney, where a CT scan will show blunt or flattened renal calyces. Other complications of acute pyelonephritis include renal papillary necrosis, paranephric abscess, and urosepsis, which is most commonly caused by E. coli. Histology will show dilated tubules filled with a glassy, proteinaceous material that forms colloid-like casts as a result of chronic inflammation. Since the tubules filled with colloids look similar to thyroid tissue, this process is sometimes referred to as thyroidization of the kidney. Now, important risk factors for chronic pyelonephritis include anything that causes chronic obstruction and urine stasis, like VUR or kidney stones. A special type of kidney stone, called staghorn stone, due to their size and branching nature, are associated with Proteus infections. One high-yield fact is that Proteus infections alkalinize the urine, giving it a distinct ammonia smell. Chronic Proteus infections can lead to a very serious type of pyelonephritis called xanthogranulomatous pyelonephritis, or XGP, which is characterized by necrotic, hemorrhagic masses containing foamy macrophages. These masses are often mistaken for tumors on imaging studies. Alright, as a quick recap, UTIs are almost always caused by an ascending infection, and the most common bacteria involved are E. coli, Klebsiella pneumoniae, Proteus mirabilis, and Staphylococcus saprophyticus. Risk factors for UTIs include being female, sex, diabetes mellitus, indwelling catheters, pregnancy, VUR, and obstruction, like with kidney stones. Lower UTIs include cystitis, where symptoms are dysuria, urinary frequency, urinary urgency, and suprapubic pain. Lab work shows normal white blood cells, positive leukocyte esterase, positive nitrites, and more than 10 white blood cells per high-power field on microscopy. Upper UTIs include pyelonephritis, where symptoms include fever, chills, nausea, vomiting, and flank pain. Lab work here shows high white blood cells, along with white blood cell and hyaline casts in the urine. Recurrent episodes of acute pyelonephritis can lead to chronic pyelonephritis, where the calyces appear blunted on imaging, and on histology there's thyroidization of the kidney. Coming back to our cases, Carmen has honeymoon cystitis that presented with typical symptoms like suprapubic pain, dysuria, and frequency. The lab showed positive leukocyte esterase and positive nitrites, and there's no increase in white blood cells. Her infection will clear out with a short course of antibiotics. On the other hand, Pamela has acute pyelonephritis that presented with some of the symptoms of cystitis, like dysuria, but she also has systemic symptoms, like fever and nausea. Her white blood cell count was high, and there were white blood cell casts in the urine, which confirms the diagnosis. In her case, she will need a longer course of antibiotic treatment.